you all so much for coming to Elaine's. My name is Jeffrey Higgins. This is my wife Cynthia's in my restaurant. We've turned it into Elaine's Literary Salon. I believe you're the 139th or 140th author I've interviewed since we've opened, so it's really fun. Thank you. And we've made this a home for authors. So if you're an author or you know one, we don't charge. Come on in, and we've created a really nice podcast as well. We think we're number 3 on Spotify, number 4 on Apple Podcasts for literary salons. So we're all things literary in the DC area, and this will be a lot of fun too. So we do.
Never been called literary.
You suffered over a book. Trust me, it is literary. So I'm excited about this one. Dr. Joan Naidorf is a board-certified emergency physician with over 30 years of experience practicing in hospitals in Northern Virginia. Her book, Changing How We Think About Difficult Patients, a guide for physicians and healthcare professionals, was published in 2022 and is widely available in electronic, paperback, and audio formats. In addition, her book reviews and opinion pieces have been widely circulated in both the Washington Post, the DO Magazine, and Doximity. After hours, she likes to travel, read, taste wine. Well, you're in the right place for that. Play tennis, follow Dolly the poodle, and walk along the Virginia beach. So please welcome Dr. Joan Naidorf. So first off, congratulations on your book. It's a really big deal. People don't, everyone, it's one of these things where about 80% of people think that they have a book in them and plan to write one, and then when they start and they go, uh-oh, this is kind of hard. Hey, can you guys hear us in the back over there? Is that good? And you can hear us back there? Okay, fantastic. So congratulations.
Thank you.
So when you talk, just talk right in and up into the mic so they can all hear you, because we don't want to miss any of these gems. So let's start with what motivated you to write this book.
When I came out of my residency, long time ago, Kathy Kelly, right over here, girl, or there, wherever, and came out of my residency. I started my first job at Alexandria Hospital, now called Inova Alexandria Hospital, and 2 weeks after I started, I turned 30, so it was a long time ago, and it was my dream job. I always wanted to be an emergency physician. When you're a medical student and in your residency, you rotate through different fields, and you have to kind of decide what you want to do. And before that, I thought maybe I wanted to do something else in medicine. But then I discovered emergency medicine. I discovered that is it. It's so wonderful. You get to kind of put together puzzles, figure out what's happening with patients, get to do a lot of procedures in addition to what you think about, and then at the end of your visit, you get to say goodbye to them. And this is like the best thing ever. So what I could not understand was after that experience, and I made it through residency, and it wasn't easy getting into that residency program. I spent 4 years in a residency program. I came out, I got my first job, and I would come home from a lot of shifts unhappy. And I couldn't figure out why. Of course, probably those of you who know me know that maybe it's part of the personality. But I was doing what I really wanted to do, but there was something going on there that was really making me unhappy, and that was dealing with some patients, what I call difficult interactions. The shorthand term we use is my interactions with difficult patients. And everybody who takes care of patients in some way, shape, or form kind of understands what that means. But it's not just patients. I'm sure some of you have students or other clients or people that you work with who you need to continue that relationship with. You can't just say goodbye to them, but something about their behavior makes it really difficult for you. So I decided to research the problem and see if I could figure out a way kind of understand some of the literature on it. This is what we do in medicine. We do research in that way. I didn't actually do research with patients, but just what was written about it. And I found out there were some things written about it, and I kind of came up with an approach to deal with the problem. And I wrote a lecture about it, and I presented at that time,
This is right after you started. You're fairly early in your career.
So it was like 1990 or 1991. It gave a grand rounds presentation. At that time, our emergency department was staff. We were part of the faculty at George Washington University, their emergency medicine program. So I gave grand rounds there. with this presentation. The director really loved it. He asked me to give it the next year, which I did, and I tried to incorporate some of those lessons into how I practiced. And then I put it away, and it's so old it's actually on pin-fed paper. Does anybody remember what pin-fed paper is? Yeah. And I had children. I had 3 children in 2 years, and still working as an emergency physician took a lot of time and energy. And then when I, kind of at the back end, when I was, found myself with a little extra time and kind of coming out of emergency medicine, the clinical practice of emergency medicine, I decided I should dig that up and give the lecture again to residents and students, because it's a really, really important message. And it's a message of learning how to accept your patients. And then I kind of learned some new things about how to do that, which I incorporated into the book. So that's the backstory.
No, I love that. It's perfect. So, I'm actually curious, because in the book you reference some papers and things, but they're from the 70s. Like, there's some older material. Was that the stuff just when you first started researching it, but in the interim decades, right, after you wrote this, was there other new research material in this field, or was there much of it?
Well, it's a difficult concept for healthcare professionals to kind of admit that we don't actually like some of our patients. It's not something that you go around talking about. So the first time anyone really talked about it, or the seminal paper on this, was a guy named James Groves. He was a psychiatrist at Massachusetts General Hospital, and he wrote a special article for New England Journal of Medicine. And this is so, in the 25, 30 years after this, people are still referring to that original article, which is called Taking Care of the Hateful Patient. Those are his words, not mine. But it was very important to try and, because I think I look at, the way medicine evolved in our country was basically men practicing medicine with this very kind of godlike paternal, structure. People looked up to their physicians. You did what they said. They took care of everybody like a kindly father. But in reality, physicians and nurses and other healthcare professionals didn't like some of their patients because they were really difficult to deal with. They didn't follow our advice. They didn't take their medicines. They didn't make follow-up appointments, all the things. And so what he did was he kind of broke down into 4 different kind of stereotype categories to help us understand. And what he did, and what I kind of have picked up on and wrote about in the book, is for us to try to understand our emotions when we're dealing with the patients, and because those give us really useful clues as to what we're dealing with and how we could, the kind of results that we're getting. So his is very much in the realm of more like a psychiatric diagnoses, because he was a psychiatrist, but you can easily see how those kind of categories apply across the board.
So when you're having a psychiatrist do this, you're talking about interpersonal relations, right? So that doesn't necessarily deal with the exact illness or trauma that a patient has suffered. So did some kind of employee assistance program, or did any kind of, within the hospitals, does any program address this? Because it seems like that would be something that's like how to make your engine function better, right? To deal with the way that the doctors and nurses and all the EMTs and everybody are actually dealing with patients.
There are the ways that employers try to deal with this are very kind of results oriented, and almost like they look at almost like as if medicine was like a hospitality industry. We want to try and make people happy, but of course sometimes our patients want things that are bad for them, and we know it, and we have to kind of disappoint them and not give them what they want, but we have to try and make them understand why. So the answer is they are coming at and giving, and there are lists out there how to talk down hostile or aggressive patients. Those are more things to do. My book talks about more ways that you can change the way that you think. Because believe it or not, it sounds, trite, but if you could wiggle your thoughts and get them to a more positive place, your actions and results will naturally follow.
So is it wrong to assume that then, like hospitals or a lot of medical facilities are more focused on just fixing what they need to fix in order to deliver the service, but they're kind of ignoring the service provider, right? They're ignoring the person who's working with the patient, because a happy employee is going to be a better employee.
Our patients are given surveys, either after they've left the office, just how was your service? Did you get what you want? Again, it's important for us to make them understand that they are getting what they need, which is not necessarily what they want. But I think it's important to address what they want. And I don't know how well various businesses and my experiences in the emergency department, it may be different in people's private offices, how they deal with making patients' expectations kind of come close to what they're getting.
So these surveys that the administration is doing, are they taking into account that a patient may not know what's right for them and that the doctor or nurse at the time is actually administering some kind of intervention that's necessary?
No.
Oh, good.
No. And I use this example as many of you know, my husband is here. His name is Toby Naidorf. He is a gastroenterologist with Inova, and his company, that company does surveys. Some of the surveys, they actually print people's actual words online, what they're thinking. I don't really understand there. And one patient a few years ago, I hope I can say this, Toby, one patient complained that Dr. Naidorf spent too much time with her. Yeah, and thought maybe he was doing that to jack up the bill. So what he does is, okay, John Langan said, were you?
Business strategy, I like it.
Yeah. So a lot of our, your interaction with a gastroenterologist, a lot of you are preparing for a procedure. So, if you haven't had that procedure yet and you're 50, you need to call him. 45 now.
We'll be doing inspections in the back here.
So you're, you have to take a prep the night before, and there's a certain way that you have to do it.
We don't have to go into the details.
No, we're not going to do it. But,
we are a restaurant.
But we give the patients have to have the instructions. Now you probably can't hear it too many times, but he makes it a practice to go over them with himself. And I'm sure this lady never had a doctor ever take the time to do it before, and actually put this complaint, and they put it on the website. So just to show you how absurd, that is, that no, they are not taken into account.
The parallels with writing and reviews really strikes me here, where you can have two readers complain about the same, one complains about it and one loves it, the same exact part of a book. And here you're getting, you're actually spending too much time with me. You're too attentive to my needs. We must stop that. So let me ask you, just on the book itself, how long did it take you to write the book? I'm always curious. It's the first book, right?
This is the first book. Now, I had that lecture, which I kind of call the skeleton, the bare bones. And I took, almost like a slide or two and made them into chapters and then added chapters. So when I decided to write a book, which by the way, a friend of mine, I had started writing a few pieces online, and they really liked it and said, well, I think this is what you should do now. You should write a book, which I had never really thought of before. It wasn't like this was an aspiration of mine, although I've always liked writing. So I decided I would write a book, and I decided to write a chapter. I set a goal for myself, kind of like this focused time, 1 or 2 hours a day, and had a computer, just put the computer was in the kitchen because I had just gotten Dolly, our poodle, who, of course, needed to be near the door so we could take her outside. So it was basically written at the kitchen table. I did about a chapter a week, so there are 17 chapters in the book. So it took me about 4 months of, it was of 2020, from January to March. And yeah, it was actually started before COVID. Of course, one of my kids, celebrated New Year's in Australia and came home with this, had this infection, which laid her out for like a week and a half. I'm like, what? I mean, you're like 27 years old. Why are you so sick? And yeah, COVID. So we, at that time, I had like the first draft. And do you want me to continue with that story about how I got it?
I'm curious.
So,
Right?
okay.
It's interesting because it's kind of different for every author, but it's also, there's a lot of commonality.
This is very, I think, interesting or unique story. At this time, I appeared on a podcast. Kevin MD, he does medical podcasts, and before or after, you can talk to the host. It was all remote, and I asked him, I said, well, you wrote a book. How did you do that? He said, well, I have a publisher. I'll send you her name. And he sent an email and introduced me to her. And she was going to come tonight, but she got a chance to go to her daughter's bachelorette weekend. So I said, that sounds way more fun.
Hey, things are going to get wild here tonight. Just hang on there, Joan.
And so I just sent the finished manuscript to her. And, I mean, when I say finished manuscript, it's like 30,000 words, is about 110, 120 pages worth of text. And she, after a month or so, or a couple months of reading it and looking at it, she said, well, I think we need to take the next step. I'm like, what does that mean? She says, well, I'll send you a contract, to publish it. And I'm like, sounds good. So I'm not like going to look for other publishers after that. Like, I know a good thing. I'm not the brightest brightest light, but I know a good thing when I see it. And when a publisher, on your first, ask or query, someone comes and said, I'll publish it for you. And what she said was, and it was mostly written for like the emergency department milieu, like as I call my peeps. But she wanted me to expand it to other healthcare professionals and other, parts of the field. And really, all the ideas are the same theories of dealing with, the difficult interactions and patients. So I did that. I did a rewrite, a second draft, and that whole process and going through the publishing, I say it's like having a baby or two. It takes like, at least 9 months. It took, and it ended up coming out in January of 22.
So how was it coming out with a book? Because that happened to me too during COVID. Was that disappointing because you couldn't do the in-person events, you couldn't do book signings, all that kind of fun stuff?
It was a little disappointing. I feel like, you feel like if a tree falls in the woods and no one's there to hear it, did it really happen? If you publish a book and no one really knows about it, is it really a thing out in the world or making a difference? I mean, and the reason I wrote it is to try and make a difference, to keep young clinicians or older clinicians at the bedside. And, this very vexing part of our practice, the challenging interactions, I feel like we could do so much better with that. And there's so many of our colleagues, especially during COVID, who were, looking for the nearest exit. And rightfully so, things were impossible. But I wanted them to get that message, and a lot of the ways to publicize kind of were not available because of COVID, like, to be doing it in public. I mean, I would have probably had the first big party at our house.
So, you mentioned new employees or veterans with a lot of experience. Who is more open to looking at this? Is someone who's been doing this for a long time open to hearing that maybe I've been thinking about the problem wrong all this time?
I think people in training are a little bit more open to hearing it. or kind of newly out. I think some grizzled veterans probably think, I don't really need to hear this. Of course, I don't think that's true. I think some of grizzled veterans, I'll include myself among them, fall into really, really terrible habits over the years. And we can't even see that some of the things that we think are not the truth. We just think that we're observing reality when really we just have a very judgmental thought about a person or a problem. And one of the persons who wrote one of the things you had to do is get blurbs. Blurbs are what the little things that are like in the front of the book and on like the Amazon review. So of course I didn't know anybody. I'm sure you've done this for your books.
Yeah, everyone's forced to do it.
Yeah. And so I had to go to total strangers. And by the way, the people I did know a few people. Most of those people said, sorry, I'm too busy. And the people who were the kindest were total strangers. Interesting. And one guy said, he said, people ask, I get like 5 of these requests a month or something like that, very kind of dismissive. I'm like, okay, no pressure. If you like it, say something. If you don't, no problem. And he kind of came back and said, I didn't even want to like it, but I loved it. And
how great is that, by the way, when you get somebody like that?
Yeah, and he said, it made me a better doctor, which is like when if you have enough humility to realize that and to kind of accept that, new thoughts, that's what it's all about. So, yeah,
because people get so wedded to their positions, right? Is it, and especially when you talk about somebody who's been in the business for a long time and they're a little jaded and they've been through all this, is there any kind of like magic bullet or some way to make them step back and be able to kind of look objectively at their interactions?
I think that pointing out to them, some of the ways that they're thinking, these are they start out, and all of us who are going into this profession, we do it because we really want to help people, we love people, and then when you kind of look at some of your thoughts or saying, or we call someone a name, which is like really mean, and everybody in our workplaces are using those names. So it doesn't even occur to us that not to use those names, and then someone else hears it, or someone says, you really shouldn't, that's a terrible way to refer to another human being. And people are like, yeah, I guess it is.
So how much of that's like a corporate culture, right? That at some point that just becomes normal and people just lose sight of it. Doesn't it sort of slide downhill from that point?
Yeah, I mean, you walk into like a nurse's station and you hear them, I read a lot of stuff online and they're talking about people say something you didn't know about healthcare, that the nurses or doctors are talking trash about their patients. Mm-hmm. And they're not wrong. They are, but it's one of the ways we're kind of laughing, the way we kind of deal with the stress of the situation. We're not kind of laughing at you, but we're kind of laughing with you, can you believe this happened? But I'm trying to steer people away from it.
Well, I mean, it's obviously not good behavior, but also it's one of the most stressful jobs on earth, right? You're in an emergency room. Every decision you're making, or most of them are life and death. And having some black humor or having something to break the tension is kind of understandable in some ways.
One of the kind of, it doesn't even start out to be mean-spirited, but we just refer to people as their room number. Because we don't have the time to learn people's names. In fact, we don't even want to call people by their names because you're in this public setting and there are HIPAA violations, so you don't want to, say, there's Mrs. Callahan. You say the lady in bed 10. Or even kind of worse is you'll say, well, the sickler or the cancer patient or something like that. So it's very dehumanizing. We fall into these traps because just everybody just uses this terminology. To us, it doesn't even seem bad. I know that, when you're not in the profession, it probably sounds like, how could you say that doesn't sound bad? Of course it sounds bad. Toby says in his profession, the people who, Terry's a nurse anesthetist. We need for people to not eat anything before their procedures. So of course they get hungry and they come and they say, well, I took the prep, but I ate. They call them eaters. Yeah, I mean, you can't have a procedure for one thing. It's
serious. Yeah.
They get very angry. It's a problem. They're difficult. They get very angry, but they're at risk to aspirate. We don't want the food going in their lungs. And then on the back end, it has to be clean down there for them to see anything. And if there's stuff in the way, they can't see anything. So then you have a procedure that isn't useful.
It strikes me a couple of things. Like, isn't one of it part of like efficiency? You're talking about a room number. Now we all know who you're talking about. Like here, you would talk about a table number, right?
Exactly.
Even if you know the person, you're sending them to the right place so there's no confusion. And isn't there a part of it that sort of self-defense on the side of the healthcare worker, where you maybe don't want to humanize too much because you want to keep that professional distance?
That's true. I think it is the challenge in each of us. We want to view our patients as real people, as people who remind us of our grandmother or our neighbor or our friend. But when we feel those connections, when there's a bad outcome, and invariably there's going to be a bad outcome, everyone is going to die at some time or another, and one of us, or emergency department, or some physician or nurse is going to be the person taking care of that person. And sometimes, being the right person to shepherd someone through that part of life it is what we're being asked to do. So, what I advise for people to do as part of the book is to just allow yourself to feel those emotions. Sometimes you want to feel sad. Some horribly sad things happen in our profession. I mean, you probably, the latest TV show has some of these things in there. All those things are taken from real life. Every single one of us who's worked in an emergency department has heard what we call the scream. The scream is, a parent who's just been told that they've lost their child. And we just know what that means. And it's horrible. And, I had many times, I'm sure Lydia has, Kathy Kelly, many times had to go in and tell parents. I mean, I tell people that grandparents have passed, and then we also have to tell parents that children have passed. And it's one of the most difficult parts of our job.
I can imagine. So getting into the content of your book here, so like what percentage of patients do people in the medical profession consider difficult?
When they've actually done some research on this in an internal medicine practice, 10 to 15% of patients are difficult. I think an emergency department probably a little bit higher. But so, if you're seeing 20 patients in a day, which like in a busy emergency department you would, that might be like 4 or 5 people that are really, if you had your druthers, you wish they weren't there. But you have to deal with them.
I mean, it seems like in an emergency department where almost by definition things have happened in an unexpected way, right? It's not a long-term care plan, that the tensions would be incredibly high, and that it would sort of breed that where people are in shock and people are in trauma. It seems like, if there's any break in the psychological fabric there, it's going to happen when you're in an emergency department. Is that fair?
Yeah, I mean, we're dealing with these situations. I talk about the kind of stresses that the patients are under. They have no idea what's happening to them. They maybe have done a quick search online and have, the first 4 things that they read are horrible. So they're always, they're worried they're going to die, or die right away. I mean, everybody's going to die eventually, but we don't want them to die right away.
Don't get all technical with us here.
And so there's a lot of stress. They're worried about, and they're comparing it to other experiences that they've had. Some people have had terrible traumatic experiences in medicine, what we kind of call medical PTSD. And to be fair, we treated children back in the day very badly. We didn't think that they needed anesthesia. We didn't think they needed enough pain relief. So we have this one of the beginning of the book, I talk about the factors on the patient side that we have to consider that are kind of bringing them, why they're not being ideal in their interactions with us.
Well, so how are they characterized as difficult, and what is the behavior they're exhibiting that puts them in this category?
There's a pretty wide range. For some are angry and aggressive. I mean, unfortunately, a lot of emergency department patients are violent when they don't get what they want. And they are, on a lower level, they're frustrated or angry, they're non-compliant or they're not adherent to the plan. We've asked them to do something or go somewhere and they don't do it. Or to wear a splint, or to use crutches. We give people these instructions for a reason. And if they can't, we don't want you to put weight on, your ankle or your broken leg or something. If you do it, you're making it worse and not better. So these are the type of behaviors that we're kind of categorizing as difficult or difficult interactions. And for those of you dealing with children, not so much with the patients themselves, but the parents. And sometimes the parents, in their zeal to do what's best for their children, are not doing what we ask them to do, have some kind of unrealistic expectations about what they can get or how quickly they can be seen.
Are healthcare providers using like heuristics when they go in there? Like, is there a certain behavior that they see and it's like flipping a switch and now that person's in the difficult category?
Absolutely. Well, heuristics are kind of like little cheat codes, and Jerome Groopman wrote a book called How Doctors Think and talked about heuristics. And when we see difficult behavior, we definitely kind of get our guard up and think a certain way. And it's probably not as charitable as we would like. So, yeah, that is true. And some practices actually red flag. I spoke to a lady I know who is an OBGYN, practices in DC. She's retired now, but she said in her practice, this is when they had paper charts, they used to put those little green dots, like the little tags, that would tell anybody who picked up that chart that this is a difficult patient. And
there's a Seinfeld episode about that. Have you ever seen it?
There's a Seinfeld episode where Elaine sees, somehow she looks at her chart and sees that she's been labeled as a difficult patient. And this, of course, and then they show the doctor as soon as he sees it, he basically like closes the chart and walks away and doesn't listen to her anymore. So, of course, she wants to put Kramer on the job to go back in and steal the chart so he can change it. So it's pretty funny, but so it's, like, this is a real problem. People, even on comedy shows, they're...
So part of your book is trying to explain to medical professionals what's happening here, right, and make them look at these interactions in a different way. So what are some of the things that the patient is feeling and that's driving this behavior that maybe the medical provider needs to take into account when they're having an interaction?
Well, this is a big part of what I'm trying to tell people. Usually the reason that people are not following instructions or are unable to follow the instructions, either they can't afford a medicine, they don't have transportation to get to a follow-up appointment, they have some other obligation like picking up a child or taking care of a grandchild that prevents them from showing up for a dialysis appointment or something like that. So instead of what I'm trying to tell people to do, instead of just labeling them non-compliant, which is really, kind of a bad thing to put on someone's chart, but it gets put on there all the time, that people should lean in and try to find out why. Now, for busy docs and nurses that can't always do that, but we do have resources to help people, like with prescriptions or with transportation. But if we don't even know what the problems are, we can't put people together with the resources.
So for everybody who's been in like an emergency room and the chaos that's happening and the people coming in on a Friday night or something, how realistic is that for the healthcare provider to try to, they have a difficult patient who's resisting and causing problems, to really stop? And let me dig down and find out why you just threw a specimen at me.
Okay, not very. However, there are ways to not escalate. And then the problem, so I have seen this. People come in hot, aggressive. Our natural tendency is to get our back up and to be defensive, which is, like the second act of war. And what we really need to do is step back quiet, to not mirror their emotions. I call it mirroring emotions, one of the things that the healthcare professionals do. It's an evolutionary thing. We mirror the emotions of our parents, but when our patients come in angry and hostile, it's very important that we don't act the same way. But every single one of us, and I'm going to raise my hand here, has probably found ourselves yelling at a patient. And when it's almost, you have to kind of like, okay, I just heard that. I got to step back, bring it down. One of my colleagues, when I was working at Fort Belvoir, got so angry at something going on in a room, he went in and put a patient in a chokehold. Yeah, I mean that.
Which page of the manual is that?
Yeah, that was not, and he was taken out by the military police. That was terrible. But just to show you how kind of triggering the whole thing was, and like, for him, it's like, I don't know what he was thinking, but he went off.
Is there any kind of in-service training where like doctors and nurses are told like de-escalation tactics, like lowering their voice and letting people vent and those types of things?
Yes, there are, and those are kind of like in the book I talk about the think, feel, act cycle, about changing your thoughts so that you can. Your emotions are a little bit better, and then what you do or don't do follows from that. So those kind of lists come from just the do part, which is good. It's good to do, but it would help if you kind of get yourself to a better part of understanding and curiosity. So that's what I talk about.
So I'm interested, in the book you talk about like doctors sabotaging themselves with this mindset a little bit. So how is it, obviously it's bad for the interaction, but how is it bad for the medical professional?
Well, what's bad for the professionals is that at the end of the day you feel terrible. And you feel like maybe I made a mistake spending the last 12 years of my life training to be a physician. And there are a lot of parts of our profession that might make you feel that way. But like, again, I said on this part, we could do a lot better. So we don't, most of us started, we filled out those applications for PT school. Madison's a PT, and nurse anesthetist. We filled out those forms and applications because we wanted to help people, and we want to, help people feel better. So to get to the point where we actually hate people, that's a very sobering thought. And most of us don't want to be that way. At the end of the day, we don't want to come home and feel terrible. I mean, this is what I'm trying to get people to remember. 15 or 16 people were happy, or at least they were satisfied. And, when you're dealing with kids, if you do the right thing and have given them the proper dose of acetaminophen or ibuprofen or something, you actually get a smile at the end, which is like magical. So you want to remember those feelings are happening and kind of diminish the feelings of the interactions that went poorly. So it's a given that some of the interactions are going to go poorly. I'm not telling you that you can get rid of all of them, but my goal is to make people realize, okay, that was only one or two out of your shift, so it's not that terrible.
So there's a lot of like efficacy and cognitive behavioral therapies, and like a big step in that is understanding what the problem is to begin with. Have you found that like writing a book like this or doing your lectures, just making the people that you're lecturing to aware of this somehow can maybe make them stop or take a pause when they're kind of sliding down that hill?
Yeah,
before
absolutely.
they choke somebody out?
So these ideas are really borrowed from cognitive behavioral therapy. And if you realize that every patient that walks in through the door is this kind of event or circumstances that is absolutely neutral. And by that I mean there's nothing going on there until a doctor or nurse or physical therapist or counselor has a thought about the person, okay? So now, like a lot of us will agree when we see something terrible that we have certain thoughts, like it's very sad that something happened to someone, isn't that unfortunate? But, people have different thoughts about the same people, and we can nudge our thoughts in a more and think with more intention about some of our patients, even some of the return patients who we see a lot, who come in with the same problem, and try to be, if we have more charitable thoughts towards them, we can kind of put the pause there and say, what would I like to be thinking about them? And then we can, view them with more curiosity and more empathy.
So, I mean, this seems very common sense in a lot of ways. So how do you get this message out to people in the medical profession? Like, do you have hospitals that are interested? Do you have universities? Like, what have you done to try to get this out, and where has it been received?
It's hard to get it out. I don't have a academic position, so I don't have that advantage. I have myself and my mouth and putting out there on social media. The people who, when you get to a certain age, like I am, the people who I went to med school with are people who are like deans of universities and or emergency medicine programs. And so I've tried to reach out to those people. At the beginning, when the book came out, I tried to send out to people electronic copies to people who I thought would have some influence. I'm going to get around to a few things that I've spoken at, like just a couple of weeks ago. So I sent a book to a guy who was a resident in New York at Maimonides Medical Center. This was during COVID, and he loved the book. He told me he would read a chapter of it before every one of his shifts. He found it like inspirational. I call it like self-help. And he said, would you be willing to come and speak? Someday I'll find out about it. So this, like almost 4 years later, I got a email from, this is through my webpage. She said, can you come? She's a medical education resident at Maimonides Medical Center in New York City, okay, in Brooklyn. And she says, can you come and speak to us? We don't have any money to pay people for things like this. I'm like, okay, I'm gonna come do it anyway, because my daughter has an apartment in Manhattan and I can stay over and get a train. And I took the subway over to Brooklyn and I spoke to them, about 40 or 50 residents. They seemed to really like it. I think that this dovetails into what you said before. I think that residents are just coming out and not having a little bit of this cognitive dissonance, what they thought they really wanted, which was a career in medicine. And then when they get there, they're not that happy. It's not what they thought it was going to be. People don't want to take our advice. I mean, like I just studied for 8 years and you don't care what I say? Yeah, that's happening. And so they need a little reality shakeup, and I need to kind of explain to them what is happening and how they could make that aspect better for themselves. So I spoke there about a year and a half ago. Keck, which is the medical school at the University of Southern California, invited me to come and do a grand rounds there. I was very excited about that. I have spoken at continuing medical education conferences. I'm trying to get the word out there. Anybody?
Children's Hospital of Westchester.
Oh, that's right. Thanks, Leah. A children's hospital in, where was it? It was in New York. It was Westchester. They asked me to come speak to the staff there. I don't know, it's really hard to know how people get a hold of your book and they reach out through the website. A local doctor, I thought she might come tonight, She asked me to come speak to the residents at Walter Reed, and then she asked me to come speak to the faculty there, which I did. So when people see it and ask, I'm willing to come. So if anyone knows anybody or thinks, I'm willing to do I do online things and also in person.
Are you offering like consulting services? Because it seems like this is sort of a win for everybody, right? The hospital can avoid some liability, they can make their staff happier, a better customer experience. I mean, the whole thing. And you could offer this to them. Or are they just not buying into it? Like they don't want to spend the money or the time because they think things are working as is?
Well, the book is actually published by American Association for Physician Leadership. So theoretically, it's kind of being pitched to people who are in leadership positions in hospitals, people who are like chief medical officers. I was hoping there would be a little bit more from that outreach. But I think I think this is true for authors. So much of publicity and marketing is kind of from your own experience and putting yourself out there. And basically, I'm shy. So it's a little bit of a struggle. It's a little bit of a struggle, but I'm working on it.
Well, you're doing great with
Thank
this. So I'm going to go around and we'll take some questions. But first, I just wanted to ask you, what was the most surprising part of this whole thing? Because everybody has an idea of what the whole process of writing a book and getting out there is. Was there anything that really kind of surprised you, whether it was something that was harder or easier?
It was a little surprising that it kind of, for lack of a better term, fell into my lap without working that hard to get it. And what I hear from other authors is that they're like pitching their ideas and trying to get an agent. And people come to me actually almost like an expert, and I'm kind of like mentoring people, which is kind of like breaks my brain a little bit. And I'm happy to give advice. I don't know what it's worth, but a little bit of the advice is just about writing and trying and going to various, just be willing to keep on asking people. So I think people have come to me and asked for advice. I also, one of the other little gigs I have is that I review books for the DO magazine, which is written for osteopathic physicians. And so a lot of people have written books and want me to review their books. So I have had to read some not so great books. I have read some wonderful books for that column, and if anybody needs some recommendations on various books, I'd be happy to give them. But so I have some sense of what is good and what is not so good, at least what I enjoy to read.
Do you have a website where you put up...
Dr. Joan Naidorf.
And do you put up book recommendations on that? It's not a bad idea, because sometimes you do that for other authors, and a reader certainly want that, but then they can do it for you as well.
Well, I do. There's a blog on there. It's called After Emergency Medicine. I also post the blogs some other places, medium.com, sometimes just on LinkedIn, if it's kind of something that I think belongs on LinkedIn, because I do some travel stuff, but I do all the book reviews on there too, because I think it helps. I know that there's a doctor in Michigan. He wrote a book called Autism Revealed. It's a pretty dense book, but I think, I'd really like to help him get the book out there. And I read it. It's hard to read. Like it's not something like a novel that you pick up. But for someone who needs like a reference in that category, it's useful. The magazine didn't want to publish it, so I'm just putting it out on my own website, and I'm going to hopefully just put it on his Amazon page. The reviews are really helpful, I think. I've asked a lot of people to write reviews, and a lot of people have been kind enough to do it. Yeah.
Well, that's great. All right, if you would stay here,
Yep,
and I'm going to
here.
walk around, and if anybody has questions, just raise your hand, and I'll ask you to speak right into the microphone, and this little one too, so it comes out on our recording.
Hi. I was wondering if your lectures have changed at all with the internet being bigger and people doing like Dr. Google more, with like coming into the ER or to whatever healthcare provider, being like, well, I have these symptoms and Google says I should do this, so why are you not doing it?
So one of the ideas I'm tossing, the question was, have things changed because people are Googling their symptoms? And of course the answer is yes. Not so much in this book. I mean, it doesn't probably make some people more challenging when they only want to hear what they think that, their 20 minutes of a Google search might equal my 12 years of training. But it's not a thing. But, I think what I tell people, I'm glad that people look things up. I'm writing some information for people, perhaps a next book, about how to be a smarter patient. And there's a certain way to kind of bring that up, like I don't think any doctor wants to be upstaged by saying, I think I have this. Just like, oh, I'm a little concerned that I might have this diagnosis. I can remember back in the day, if you're old enough to remember what a newspaper is, a patient I was seeing at the hospital, he had a very bad headache, and he told me he was concerned that he had temporal arteritis. Temporal arteritis is like a vasculitis, inflammation of the veins over here in the temporal area, very severe pain. Well, he was sitting there reading the Washington Post. And I said, well, I assure you, if you had that problem, you would not feel like reading the newspaper. So, but it's good that people, because you know what, you have to address what people's questions are. Because sometimes the questions are in left field. I probably would have seen that guy and gone through the workup for, a headache, and would have never said to him, I don't think you have temporal arteritis, which are like the words he wanted to hear. And I would have never thought that because it wasn't part of my differential. Probably should have been, but I don't remember exactly what I was thinking. But people come out with some crazy stuff. One of the stories I used to tell that is I saw a child, which in retrospect this sounds kind of weird, but he had a little burn on the tip of his penis. He was like a 2-year-old. Some boiling water flopped over like someone cooking rice, and it was almost nothing. It was like, it looked like the head of a little eraser tip, little red spot. And I asked the father any questions, before he was leaving, everything was good, we're sending him home. And he said, yeah. I said, oh, what? He said, can he be a father? I didn't think of that. I'm like, oh yeah, it won't be a problem.
You have other questions on this side?
Hi. Thanks for doing this tonight. I've been excited to see it for the last few years. I'm her daughter, for those of you I haven't met. What was the most difficult part of writing the book? Don't say me.
The most difficult part of writing the book, hands down, was having to provide the author headshot. Okay? This, if you know me, you know that this is kind of how it looks, and it doesn't really get much better. It gets worse. And, I'm not about, makeup and hair and all that stuff. So she says, the first thing she wants is an author headshot. Kathy Weisblatt, who was here a few minutes ago, one of her friends is a photographer and does, a lot of, she comes in and does the shots, outside, so you have natural lighting, and takes lots of shots. So I had to, this is what I went through to get the author headshot. I went to Sephora and said to them, teach me how to put on makeup and sell me some makeup, which I did. And because I wasn't going right to the headshot, she had to teach me, and believe me, I only learned about 10 minutes of the hour session that we had, and and I went to the hair salon, which is like right around the corner here, Aquilano, and I had her do my hair, and I think that was maybe the day before, so I could just do it, and I had to wear something, which I thought would be, kind of complimentary. Went to the backyard, it was a nice day, and we got the shots, a lot of shots, even there's one cute little shot with Dolly, the poodle, yeah, we got something usable. But that was way harder than writing the book.
Other questions here?
Joan, in thinking about patients' self-realization in their interaction with a patient that will precipitate what they feel and think and do, is the remote visit that physicians now are adopting increasingly going to hinder that self-realization about their response to a patient in terms of how they're going to think and feel and do, or not?
Well, I think it will. This is my friend John Symington, who's an amazing physician, probably never met a difficult patient, and I admire people like that. I'm not saying he has them, but he finds them, something interesting about them. I think it's a really important part of telehealth, but I think that the physical exam is so important, and you have to, that sort of interaction between the professionals and our patient takes such an important part in person. And for physicians to touch their patients is really important. The first thing I always would do when I would come into the patient's room would be to grab their hand, which they probably thought I was shaking their hand, which I kind of was, but I was like feeling their pulse. And because you learn a lot from that, like if they're sweaty, if they've got a normal pulse, and if they're not, there's some arrhythmia or whatever for our profession is really important. So I think it's going to have a negative effect. Do I think, it's almost what I tell, and my friend Kathy Kelly is doing some telehealth now. It's almost being used as the first triage layer to get you to where you're supposed to be. So that's what I think.
Okay. So you have some books up here for sale, is that right?
Well, there are a few. There aren't very many. So if anyone needs them and we run out, I can figure out a way to get to you. This book is available online. It's available electronically, as a Kindle version. People like to read it that way. It's available as an audiobook.
Do you read it?
I did not read it. So those of you who know me can imagine my voice, but if you've figured out, I'm from New Jersey, and I have a strong New Jersey accent, and we decided we needed a professional.
It's incredibly hard to read a book. It's a whole performance.
Yeah. No, I love audiobooks, and I knew that it would be a bad idea. And it's narrated by a female doctor, because I made a conscious decision to make all the pronouns, the physician pronouns, she. And why not? It's my book.
So what is your website again?
drjoannaidorf.com. It's drjoannaidorf.com.
All right, wonderful. So I have two requests for everybody here or who are watching this. If you could go on Amazon and just leave her a review, it takes 30 seconds, and it makes a really big difference just to get some visibility for the book and trigger those Amazon algorithms. And my second thing is, if you like what we're doing here at Elaine's Literary Salon, if you could jump on Google or any of the sites, Open Table, where you rate restaurants, and leave us a nice review. We'd really appreciate it. So you'll be signing books up here?
Yes.
Okay, well, thank you. Well, Doctor, it's been a pleasure. Thank you so much.
Thanks for having me.